We have some time for questions. Maybe, Teresa, if you want to come up to the table, and Paul. Sí, va a haber tenemos un tiempo para preguntas relacionadas con las charlas, por favor. Sí, o sea que si tenéis preguntas para sobre todo, vamos, quizás va a haber más cosas luego en las otras charlas, sobre todo cuestiones que no hayan quedado claras sobre las presentaciones que han hecho ellos dos.
The question is for both doctors. Is there any experimental drug treatment ongoing related to cognitive?
Excuse me, can you repeat?
Sorry.
I'll take this off. I'm hearing
listening in
Spanish.
But sorry. My question was, is there any experimental drug program ongoing related to cognitive or even behavioral disorders?
I'm sorry?
Drug experimental treatments ongoing.
So I will talk about that just a little later today. The short answer is there are two drugs. One is a commonly used drug for depression. The other is a commonly used drug for anxiety, which we think now could be helpful for some of your children at least. That's what we want to test. I'll talk about that.
Okay, thank you very much.
Sí, ¿una otra pregunta? Sí.
Well, I've got also a question. Do you think that is from a clinical point of view, right, important or necessary to have a RI-CGH to all patients diagnosed, even they are older, right?
So
Is it useful?
Yeah.
Well,
increase?
if it's necessary, not useful, but necessary from a clinical point of view.
Yes.
If you have an elderly child or even a young adult that had been diagnosed by karyotype or even FISH, if it's necessary, because when you see these things, which are very, very interesting from a research point of view, but you have already seen on your lecture that, well, that's what sometimes happens, but it doesn't happen every time, right? So if you think that it's necessary, not helpful, not maybe useful, but necessary.
Yes, I think it's necessary to fully assess.
But from a clinical point of view, not for research.
Even for a clinical point of view. Maybe not so detailed. But first of all, you might see that we have seen that some children don't have Jacobsen, have another imbalance. It was a wrong diagnosis. This was twice. We also saw that some children have some additional imbalance. So this is to fully assess for clinical point of view children. I usually like to have also standard chromosomes because they add some information. Especially when you want to know if the parents may have something connected to it, because they are balanced and on an array they will be normal.
Oh, absolutely. Well, I was... Well, but that's part of the normal diagnosis. I mean, if you have an abnormal array, you have to absolutely
you have to go to parents.
Standard karyotyping. All right.
What I want to stress is that apart from very few features, on clinical point of view, you see ADHD is in about a half patients, cardiac disorder is in about a half patients, there is a high variability within patients. And this, I think, is the most important question. Because if we knew why some patients don't have even the facial features,
but that's research.
It would, yes, this is for us, yes, right. I know. But the information comes from children.
I say that because you can have a patient diagnosed many years ago,
yeah.
And now you have to tell your managers, right, that you have to re-diagnose your patient. And that's not easy in Spain, actually. I have to say that.
And the United States, too.
We do it. We do it. I'm assessing. I'm working in cytogenetics from 1980. And I am assessing my old patients and seeing many new things.
Yes, I agree.
Mostly additional imbalance in patients who were maybe odd, maybe more severe, maybe not. But I'm saying that a new assessment is useful.
Okay,
if I can add something to that as well. I think that the clinical problems and the research are so connected,
yes,
that each one needs the other, so to speak. So I think from the clinical perspective, knowing the array results will impact in the future, more in the future than in the past, maybe how we take care of these people.
Anyway, if you have patients that you want to reassess and you can't, you can tell me.
Oh, no. It was a question more for the people.
Yes, I understand.
Because many people has all diagnosed, done, right? And then they have to pressure their clinicals to have and it's not going to be easy.
Yes, I understand.
May I add something? Because sometimes what I think it's important to send the message across to parents that just because of the size and the precise location of the deletion does not necessarily, give you a prognosis.
Yeah.
Right? Because we see this in 22q11. You have the same deletion and all the children are different.
Yes.
So this is something I can understand that parents are very anxious to know, how big is my children's deletion and where is it located? And that it is very important.
This doesn't necessarily mean that your children is going to have that.
That's why I say that.
Yes. But we must know that.
Excuse me. You know, but many people here, they don't, and it can create anxiety to many people because they don't know the exact size of the deletion. And from a practical, clinical point of view, it's not relevant. I have to say nowadays. Maybe in the future, absolutely. Maybe for research, absolutely. But if you have a 20-year-old girl, let's say, you know if she has impairment, you know if she has cardiac defects, and you know many things. And it is important from research. Absolutely, I agree with you. But you cannot throw anxiety to parents to see if you don't have an array which is cannot have been done before because it was
this is not the right
available, right?
Just
to convince them. The thing is that we can update the diagnosis, not in a stressing it as we get a result and we get an answer. That's true.
Okay, I think we have to
give the opportunity. One thing, I think when I talk later today about some clinical trials, it may be something very similar, for example, to cancer. So if you look at, let's say, the treatment of children with this type of cancer of the blood, leukemia, the reason why treatments have become so much better for these children is you tailor the therapy based on the genetic cause. And I think similarly, for these chromosomal disorders, not just Jacobsen syndrome, the more we learn, we will also stratify treatments based on the genetics. So when I talk about, let's say, this commonly used antidepressant drug, buspirone, if we do see a response, we think maybe some children will respond better than others, maybe, based on the genetics. And that's, I think, a very important reason in the future, more so than in the past, why I think every patient should have an array, no matter what their age.
Okay. So that's clear. ¿Alguna otra pregunta en relación con las presentaciones?